Hello everyone. Today's topic is Faradic current. Right? Today we will discuss indications, contraindications, and application of Faradic current. So as we know, Faradic current is a short frequency therapeutic current. Faradic current is used to stimulate innervated muscles. We have two types of Faradic current. One is continuous Faradic current, and one is interrupted or modified Faradic current. This interrupted Faradic current is also known as surged Faradic current because in this there is interruption between the impulses. That's why it is known as surged Faradic current. Right? Basically, Faradic current is used to facilitate muscle contraction. So when the patient is unable to perform voluntary action, so electric stimulation is given to assist the muscular contraction. If the patient is bedridden, patient is unable to perform any voluntary action, then we can use Faradic stimulation. Right? In case of muscle re-education, we can also use Faradic stimulation. So as a result of long illness, if a muscle does not perform its function or forgets its function, then the electrical stimulation is given to act so that it can resume its function. And the phenomena is called as muscle re-education. Right? So during muscle re-education, when the stimulation is given, patient is asked to perform the contraction himself too. Means you have to instruct the patient to perform voluntary contraction along with the electrical stimulation. Then we will get the maximum result. Clear? In case of neuropraxia of motor nerve, we can use Faradic stimulation. Neuropraxia is a first degree nerve injury. In neuropraxia, there will be a physiological block of nerve impulse transmission. So to facilitate nerve impulse transmission, we use Faradic stimulation. Right? So basically Faradic stimulation is used to stimulate innervated muscles. When you give Faradic stimulation, the muscles pumps, so the alternating contraction and relaxation results in the pumping action, which results in increased venous and lymphatic return. Right? So these are the indications of Faradic stimulation. We use electrical stimulator for Faraday stimulation. In electrical stimulator, we have Faraday stimulation option, galvanic stimulation option, interferences, right? If it's a combo machine, test maybe with this, right? So we should understand where we are going to use this Faraday current stimulation. So in case of innervated muscles, if they are not working properly, in that case we can use Faraday stimulation, right? So we should understand the anatomy of muscles, facial muscles, upper limb muscles, lower limb muscles, right? So today we will discuss the origin, insertion, and action of the all types of muscles, right? In last class we had discussed sequential Faradayism in quadriceps rehabilitation. So in case of painful and chronic effusion of knee joint with a quadriceps lag, we use Faraday stimulation to strengthen the quadriceps muscle. So for quadriceps rehabilitation, we use Faraday stimulation, right? In Faraday stimulation, we use cathode electrode and anode electrode, right? This cathode electrode is a negative electrode. It acts as active electrode, and it is also known as a stimulating electrode, right? And the anode is passive, positive electrode. And this Faraday stimulation, active electrode is placed over the motor point, and the passive electrode or indifferent electrode we place over the nerve trunk. Clear? So in quadriceps rehabilitation, important thing is patient positioning, therapist positioning, proper electrode placement, right? And you should understand the things, what intensity you have to use to stimulate muscles. So in case of sequential Faradayism in quadriceps rehabilitation, this method of Faradayism uses simultaneously an electronic low voltage stimulator and induction coil to obtain maximal contraction of the quadriceps mechanism. In quadriceps, as we know, there are four components. One is rectus femoris, one is vastus lateralis, one is vastus intermedialis, vastus medialis. So we have four components in quadriceps, right? So in this, the patient's position will be long sitting position, right? With a pillow or block under the heel, or the other leg rest on the floor or the stool over the edge of the bed. Right? First, we prepare the skin area, we prepare the patient, we explain the procedure to the patient, right? Then we place active electrode over the common motor point, approximately two-thirds the way down the thigh, right? So over the motor point, we place active electrode, and the passive electrode we place over the nerve trunk, right? On the femoral nerve, because the femoral nerve supplies to the quadriceps, right? So on the medial side, upper side of the thigh, we place passive electrode, and the active electrode is placed on the motor point. What is the motor point? Motor point is a place over the neuromuscular junction where we get maximum contraction with minimum intensity of the current, right? So with minimum intensity, we can produce maximum contraction in the muscle. That is the motor point, right? So every muscle has its own motor point. So where there we stimulate and we can get the maximum muscle contraction. Clear? Now today we will discuss Faradic foot bath. The small muscles of the foot can be re-educated. So as the name suggests, Faradic foot bath, we are going to stimulate foot muscles with Faradic stimulation. That's why it is Faradic foot bath, right? We dip foot in the bathtub. That's why it is Faradic foot bath. So the small muscles of the foot can be re-educated and facilitated by the Faradic current under the saline water. So during this treatment, we use saline water. So the saline water bath for this purpose is called Faradic foot bath. So it needs a deep and long plastic bag, Faradic stimulator with rectangular rod type electrodes, a smart disto coil or low frequency electronic stimulator, that is electrical stimulator, two metal electrodes, leads, a small table, trolley for the machine, a stool covered with plastic, and the towel for bath, hot tub with warm water, towels, Vaseline, a wooden spatula, chair or a stool for the operator, right? So these are the equipments, those are required during the treatment session. So first we discuss preparation of the patient, right? So position the patient comfortably in high sitting position. So ideal position for this Faradic foot bath will be high sitting position on a plinth or couch with back well supported with pillows and the feet on a stool covered with plastic and towel, right? So patient position will be a high sitting position, and we place foot over the stool, right? That is covered with plastic and towel, and the patient should be explained the rationale for treatment and sensation to be experienced. Means you have to explain the procedure to the patient and how and what he is going to feel during the treatment. So check that there are no contraindications to treatment with Friedism, right? So always consider contraindications in your mind before giving the treatment. So first, examine the area to be treated. Note any cuts, wounds, abrasions, skin lesions, inflammations, or swelling. You have to notice. The small cuts or obstructions, obtrusions to be insulated with the sterile Vaseline. If there is any small cut or abrasion, you can cover it with Vaseline, right? Then you can go for electrical stimulation, right? Inflammation and edema impede the penetration of the current. So no skin test for sharp blunt discrimination is necessary when using the smart Besto coil, as there are no chemical effects with the Faraday current, right? But the test must be carried out when a low frequency electronic stimulator is used, right? So place the patient's foot in a bath of warm water to decrease the skin resistance, right? So connect the leads firmly to the machine. You have to check the machine prior to application. You have to check all the leads. You have to check all the knobs, right? So the foot is immersed in a tap water in a plastic tray till the water level touches the mild of navicular bone or the medial malleus of the foot, right? So we have to dip the patient's foot in the bathtub. The water level should be up to the medial malleus. Clear? In this, we can add a few pinch of sodium chloride, NaCl, to make the water good conductor. Sodium chloride is a common salt we can add in the water to reduce resistance. So patients should sit comfortably on a chair or a stool, and this chair or stool should be made up of plastic or wooden, and wait for 2 to 3 minutes so that the foot skin is well moist, thus reduced skin impedance is obtained, right? Next point is we can put one electrode near the toes and the other near the heel, right? About 1 inch electrode should be submerged into the water, right? So we can use passive electrode under the heel and active electrode under the metatarsals. Clear? To stimulate foot muscles. So turn on the stimulator and increase the intensity till the patient feels tingling sensation in foot, and fix the knob for the period of 5 to 10 minutes, and ask the patient how he feels, right? So when the time is over, slowly decrease the intensity and turn off the stimulator. Here, remove patient's foot from the bath and dry with a towel. And this treatment may last about 20 minutes. And the patient is encouraged to contract foot muscles during the session. Then the patients can get the maximum result. Right? So this is cardiac foot bath. Now we discuss motor point, stimulation of motor point. So motor point is a neuromuscular junction where we get maximum contraction with a minimum intensity. Right? So this method has the advantage that each muscle performs its own individual action, and that the optimum contraction of each can be obtained. Means we can stimulate each and every muscle by stimulating the motor point, because every muscle has its own motor point. So it may therefore be selected when training a new muscle action or when isolation of one muscle is indicated. Right? So by the Faraday stimulation, we can stimulate each muscle. Right? Each and every muscle we can stimulate by Faraday stimulation. We stimulate motor points. So the operators and the patient should be prepared as previously described. We all know. Before giving the treatment or stimulation, we should check the machine. We have to prepare the patient, right? Or we have to prepare the treatment area. Then the indifferent electrode is applied. Indifferent electrode means passive electrode, right? So the indifferent electrode is applied and secured in a suitable area, right? The active electrode may be a disc electrode, which is held between the index and middle fingers, or a small pad which is held in the palm of the hand, and it is placed over the motor point of the muscle to be stimulated, right? So active electrode you have to place over the motor point, right? So firm contact ensures a minimum of discomfort, and where possible, the whole of the operator's hand should be in contact with the patient's tissues so that he or she can feel the strength of the contractions produced, right? Operator's hands means therapist hand. So we have to check the muscle contractions when we are applying the stimulation. A suitable duration and the frequency of surge must be selected, right? So the intensity of the current is gradually increased until a good muscle contraction is obtained. Means you have to increase the intensity slowly, right? So a good muscle contraction at the maximum point of each surge, then the surging is continued to produce alternate contraction and relaxation of the muscle, right? The duration of treatment is determined by the length of the time for which the patient can concentrate on the movement and assist in its production, right? So muscle surge is means there should be an interruption in between the impulses, that is surging. Point is, a muscle fatigue is indicated by weakening of the contraction, right? So when the contraction weakens, it means muscles are going to be fatigued, but does not occur rapidly with the fatigue type stimulation, right? So we have to notice the muscle contractions during the treatment. We have to motivate the patient to contract the muscles along with this electrical stimulation, right? So stimulate lumbricals. One pad is placed transversely or below the heel, and the other below the metatarsophalangeal joints to stimulate introci. Pads are placed on the either side of the foot, right? So in both the above set conditions, patient is asked to perform foot and finger movements when the foot is under stimulation in water, right? So if the large tray size is selected, we can stimulate both the feet simultaneously in the same foot bath. Clear? So in this foot bath, if we want to stimulate lumbricals, we place one electrode under the heel and the other electrode under the MTP joint, metatarsophalangeal joint, right? We stimulate lumbricals, right? Function of lumbrical is flexion of MTP joint, right? And to stimulate introci, we can place active electrode and passive electrode on the sides of the foot, right? So this is Faradic foot bath. Clear? So you can get this in examination as a question. Quadriceps rehabilitation with Faradic stimulation and Faradic foot bath, right? So by Faradic stimulation, we can stimulate the muscle individually. So we should understand the anatomy of muscles, facial muscles, upper limb muscles, and lower limb muscles. So now first we discuss facial muscles, right? So as we know, facial muscles are supplied by the facial nerve, right? The facial nerve is the seventh cranial nerve, right? It supplies to the facial muscles. Now we discuss one by one. Origin of the muscle, insertion of the muscle, and action of the muscle. Clear? So first we discuss occipitofrontalis muscle. Occipitofrontalis, right? So origin point is the occipital part of frontalis originates from lateral to third part of superior nuchal line of the occiput. This is the occiput, right? Occipital. These are the parts of skull. Frontal, parietal, occipital, right? Temporal. So frontoparietal, occipitofrontalis. Origin point is here, occiput. The two-third part of the superior nuchal line. There is a line, dominant line that is known as nuchal line, right? So occipitofrontalis originates from here and attaches to occipital and frontal part, insert in gallia aponeurotica, right? Inserts over here on the frontal part. And the action is raising of scalp and eyebrows up and produce horizontal wrinkles, right? Horizontal wrinkles like this. So this is because of contraction in occipitofrontalis muscle, right? So if we want to test this muscle, we can ask the patient to raise eyebrows up and look as if in surprise. We can see the horizontal wrinkles on our forehead. Horizontal wrinkles like this, right? So this is the action of occipitofrontalis. Next muscle is corrugator supercilii, right? You can see in the slides corrugator supercilii. Origin point is superciliary arch of medial end of frontal bone, right? And the insertion is in the middle of deep surface of skin of eyebrows, right? So here we can get the corrugator supercilii just above the eyebrows. What is the action of this muscle? Corrugator supercilii. It produces vertical wrinkles on forehead. Vertical wrinkles, vertical means here, we can get vertical wrinkles when we ask the patient to bring eyebrows together. So ask the patient to bring eyebrows together. So here we can get vertical wrinkles because of contraction in corrugator supercilii. Right? Next muscle is orbicularis oculi. Orbicularis oculi. It originates from frontal bone, from the nasal part, from maxilla, from the frontal process, and from the medial palpebral ligament from the anterior surface. So here we can get orbicularis oculi around the eye, right? Both the sides. Insertion is the fibers of muscle encircle the orbit, descend on the cheeks, and join the adjacent muscular or ligamentous structures. Clear? So basically, it helps in closing of eyes, orbicularis oculi. So palpebral part helps in blinking and the closing of eyes gently, and the orbital part closes the eyes with force, and the lacrimal part brings the eyelids and lacrimal canal medially. Right? So orbicularis helps in eye closing because it's found around the eyes. The next muscle is levator palpebrae superiosus. All these are the facial muscles, right? So we are discussing one by one. Now the muscle is levator palpebrae superiosus. It originates from the sphenoid bone, from its inferior surface. It inserts in orbicularis oculi, and the action is elevation of upper eyelid. And it is all these muscles are supplied by the facial nerve, right? So how can we test this muscle? Levator palpebrae superiosus. We ask the patient to close his eyes and now ask the patient to raise the upper eyelid, right? So by this we can check the function of levator palpebrae superiosus. Function of levator palpebrae superiosus is elevation of upper eyelid. Clear? Next one is procellus. Procellus. So it originates from nasal bone, procellus. Here we can get procellus, right? So from the nasal bone, from the lower part of the covering fascia, and from the lateral nasal cartilage, from its upper part, it originates. Inserts between the eyebrows into the lower part of the skin of forehead. Here it inserts. And the action is it produces wrinkles on the bridge of the nose. Here, you can get wrinkles. So this is the function of processus muscle, right? Next is nasalis. Nasalis muscle around the nose. Action of this is narrowing of the nostrils and the depression of the nose downward, right? So nasalis narrows the nostrils and depresses the nose downward. So this is the action of nasalis. Next muscle is rhizodius. Rhizodius originates from fascia of the masseter, facial muscle, masseter. Insertion point is the skin of the angle of the mouth. So here we get rhizodius on the angle of the mouth. Action is it reduces backward movement of angle of mouth, right? So we ask the patient to bring light smile on the face so that the angles of mouth are drawn backwards, right? So when we ask the patient to smile, this muscle works, right? Rhizodius. It brings angle of mouth backwards. Clear? Next muscle is gynecomaticus major. It originates from zygomatic bone. Here we get zygomatic bone, right? Zygomaticus major, minor. So zygomaticus major originates from zygomatic bone, inserts at the angle of mouth, right? And the action of zygomaticus major is lateral and upward movement of the angle of mouth, lateral and upward. And it is also supplied by the same facial nerve. So when we ask the patient to do upward and outward movement of angle of mouth and to smile, right? So by this we can check this muscle is working or not, right? So ask the patient to smile and bring the angle of mouth upward and outward. So this is the function of zygomaticus major. Clear? Next important muscle is zygomaticus minor. It also originates from zygomatic bone, zygomaticus minor. From the medial side of the zygomaticus major, it inserts at the upper lip, right? So action of zygomaticus minor is upper lip elevation, right? Because it inserts here, so when it contracts the upper lip, elevates, right? So upper lip elevation is the function of zygomaticus minor. Clear? Next one is buccinator. Buccinator originates from maxilla and mandible. Upper jaw is called maxilla and the lower jaw is called mandible, right? Insertion point is at the angle of mouth along with orbicularis oris. Action is compression of cheeks, blowing action, and it helps in mastication of food. Buccinator, right? Muscle of mastication. It is also supplied by the facial nerve. So to test this muscle, buccinator, we ask the patient to press cheeks against the teeth, right? And we ask the patient to fill air in the mouth and blow, right? So this is the action of buccinator. This is an important muscle of mastication. Next one is mentalis. Mentalis, here. Origin point is fossa of the mandible and it inserts on the skin of the chin. Here, right? Both the sides. Mentalis. And the action is protrusion of lower lip and produces wrinkles on chin, right? It is also supplied by the facial nerve. To test mentalis, we ask the patient to raise the chin, right? We ask the patient to raise the chin and protrude the lower lip as if expressing doubt, like this, right? It shows doubt expression. So we ask the patient to raise chin and lower lip protrusion, right? So this is mentalis. Now we discuss platysma. Platysma is a important muscle. Originates from fascia of deltoid and pectoralis major, right? From here, it originates and inserts on the mandible. Here, inserts on the mandible, right? What is the function of platysma? It depresses and draws back the lower lip and produces tension of the skin of the neck, like this. Here, platysma works. When we contract this muscle, it's a platysma, right? So ask the patient to depress angle of mouth and lower lip and tense the skin of neck, right? So when we ask the patient to depress the angle of mouth down and lower lip and tense the skin of neck here, it means platysma is working, right? Next muscle we can discuss, that is levator anguli oris, right? Levator anguli oris. So as the name suggests, it is found over here at the angle of mouth, both the sides. Levator, it elevates the lip, elevates the angle, and oris means around the mouth, right? So it originates from fossa of maxilla, inserts on the skin of the angle of mouth, and the action is elevates the angle of mouth, right? It elevates the angle of mouth, this one, levator anguli oris. So how can we check function of levator anguli oris? We ask the patient to elevate angle of mouth, right? If the patient can perform, it means muscle is working. Next is depressor anguli oris. Depressor, here we get it. Depressor anguli oris originates from mandible oblique line, inserts on the skin of the angle of mouth along with the adjacent muscle, depresses the angle of mouth because it's depressor anguli oris, right? The action is it depresses the angle of mouth. How can we check this muscle? We ask the patient to depress the angle of mouth, right? If he can perform, it means it's normal. So this is depressor anguli oris. Next muscle is lateral pterygoid and medial pterygoid, right? Its action is elevation of mandible and protrusion of mandible and side to side movement of mandible. So elevation of mandible, protrusion of mandible, and side to side movement of mandible, right? Lateral pterygoid and medial pterygoid. This is the action. It moves mandible, elevation, protrusion, and side to side movement. Clear? The next one is orbicularis oris, right? So it inserts at the angle of mouth and it is found around the mouth. Orbicularis oris. And the action of this muscle is it closes the lips. Orbicularis oris. So how can we check it? We ask the patient to do whistling or kissing, right? Kissing action. So if the patient can perform it, it means the muscle is working, orbicularis oris. So basically it helps in whistling and kissing. Orbicularis oris. So these are the muscles of face, facial muscles. And all these are supplied by the facial nerve. So by the MMT, manual muscle testing, we can check the power of the individual muscles. Right? Now we discuss upper limb muscles. In upper limb, there are so many muscles: scapular muscles, deltoid, anterior fibers, middle fibers, posterior fibers, biceps, triceps, brachialis, brachioidalis, forearm extensors, flexors, wrist flexors, extensors, umbilicals, and trocei, right? So we start with serratus anterior. Serratus anterior. The function of serratus anterior is protraction of scapula, right? This one. This is a protraction of scapula. When we do punching action, it means protraction occurs, right? Protraction. So in this, serratus anterior works. So protraction of scapula and stabilization of scapula against the thorax. And this muscle is supplied by the long thoracic nerve, right? So when we ask the patient to do this punching action and he performs it, it means the muscle is working properly, right? Next muscle is trapezius, the upper fibers of trapezius. Action of this muscle is scapular elevation. This one, scapular elevation. And it is supplied by the accessory nerve, right? And the middle fibers of trapezius, it retracts the scapula, scapular retraction. This one, backward movement of this, scapular retraction. And it is also supplied by the accessory nerve, right? Middle fibers of trapezius, then lower fibers of trapezius. It originates from T6 to T12 spines, inserts at the apex of the scapular spine, right? And the action is scapular rotation. So it rotates the scapula laterally, right? Lower fibers of trapezius, right? So we have upper fibers of trapezius, middle fibers of trapezius, and lower fibers of trapezius. Upper fibers helps in scapular elevation. Middle fibers helps in retraction of scapula, and the lower fibers helps in scapular rotation, lateral rotation of scapula, right? And all these are supplied by the accessory nerve. All the fibers, upper, middle, and lower fibers, supplied by the accessory nerve. Clear? Until unless you don't know the action of muscles, you cannot do MMT, manual muscle testing. And the MMT is the most important part of this physiotherapy, right? Next muscle is rhomboidus major and minor. Rhomboidus major helps in retraction and medial rotation of scapula. Retraction and medial rotation. And it is supplied by the dorsal scapular nerve. Right? Next muscle is rhomboidus minor. It also helps in retraction and elevation of scapula and supplied by the dorsal scapular nerve. Clear? Basically, rhomboidus major and minor inserts on the medial border of the scapula. Right? Medial border means vertebral border towards the spine. So the retraction of scapula is done by the rhomboidus major and minor. Next one is deltoid anterior fibers. Action of deltoid anterior fiber is elevation, right? Shoulder elevation supplied by the axillary nerve. Middle fibers of deltoid helps in abduction of shoulder. Deltoid middle fibers, right? Supplied by the axillary nerve. Clear? And the deltoid posterior fibers, action is extension and lateral rotation of shoulder. Extension, right? So deltoid anterior fibers, middle fibers, and posterior fibers, all these are supplied by the axillary nerve, right? So deltoid anterior fibers helps in flexion, shoulder flexion. Middle fibers helps in abduction, shoulder abduction, and posterior fibers helps in extension, shoulder extension, right? And the insertion point, all the fibers is common, that is deltoid tuberosity of humerus. Clear? Next is latissimus dorsi. The action of latissimus dorsi is extension, abduction, and internal rotation of shoulder. Right? Latissimus dorsi. And it is supplied by the thoracodorsal nerve. Right? Next important muscle is pectoralis major. Pectoralis major, this one, it helps in horizontal adduction, like this. It helps in horizontal adduction. Pectoralis major. Right? Supplied by the medial and pectoral nerve. Next one is subscapularis. It is an internal rotator of the scapula, shoulder. Right? Subscapularis. Action is medial rotation and adduction of scapula and supplied by the upper and lower subscapular nerve, right? Next one is infraspinatus. It is an external rotator of shoulder joint, infraspinatus, because it is found below the spine. So that's why it is infraspinatus, right? It is found on the dorsal surface of the scapula, infraspinatus, below the spine, dorsal, scapular spine. So action is lateral rotation of arm, right? So it is an external rotator, infraspinatus, and it is supplied by suprascapular nerve. Suprascapular nerve, right? Now we discuss triceps. Triceps is an elbow extensor. It helps in extension, elbow extension, triceps. And this we have long head, lateral head, and medial head, right? And it is supplied by the radial nerve, right? So in case of neuroplaxia, of radial nerve, we get Saturday night's palsy, right? In that case also we can use cardiac stimulation. That's why we are discussing all these muscles, actions, and origin insertion, right? But in case of neuroplaxia, the 100% recovery is possible, and it recovers within few hours. It may be recovered in 2 days, right? So this is triceps. Next one is anconeus. Anconeus is a small muscle, acts as elbow extensor, supplied by the same radial nerve, right? Now we discuss elbow flexors, biceps brachii, brachialis, brachioradialis. All these are the elbow flexors, right? So now first we discuss biceps brachii. Insertion point of biceps brachii is radial tuberosity, right? And it is supplied by the musculocutaneous nerve, right? Musculocutaneous nerve, biceps. Next one is brachialis. Function of brachialis is flexion of elbow with forearm pronated, right? Like this. Flexion of elbow with forearm pronated, right? So this is the action of brachialis. It's supplied by the musculocutaneous nerve, right? And the brachioradialis action is elbow flexion in mid position, right? Like this. So this is the action of brachioradialis, right? Now we discuss supinator, pronator. Supinator originates from lateral epicondyle of humerus. Here is the lateral epicondyle, right? Origin point of forearm extensors, lateral epicondyle. here, medial epicondyle, right? The supinator originates from lateral epicondyle of humerus. Action is forearm supination and supplied by the posterior interosseous nerve, right? Then plantar teres and plantar quadratus. Action of plantar teres and quadratus is it pronates forearm, right? Donation, donation, donation of forearm, and it helps in elbow flexion and supplied by the median nerve, right? Plantar teres and plantar quadratus. Next muscle is flexor carpi ulnaris. Flexor carpi ulnaris on the medial side or medial epicondyle. This is the point, common origin point of forearm flexor, right? Flexor group. So origin point is medial epicondyle of humerus. It inserts at pisiform, hamate, and fifth metacarpal bone, right here, and supplied by the ulnar nerve, flexor carpi ulnaris, supplied by the ulnar nerve, flexor carpi ulnaris, right? And the action is flexion and adduction of the wrist, flexion and adduction of wrist. See, flexion and adduction of wrist. The flexor carpi ulnaris is supplied by ulnar nerve, right? Next one is flexor carpi radialis. Origin is same, medial epicondyle of humerus. Action is flexion and abduction of wrist, flexion and abduction of wrist, right? Supplied by the median nerve, right? The flexor carpi radialis is supplied by the median nerve, right? Next muscle is extensor carpi radialis longus, extensor carpi radialis brevis, component of extensor compartment, originates from the lateral epicondyle, right? And supplied by the radial nerve. The function of extensor carpi radialis longus is extension and abduction of wrist, right? Extension and abduction of wrist, like this. Extension and abduction of wrist. Also assist in elbow flexion. Extensor carpi radialis longus. And next muscle is extensor carpi radialis brevis. Action is extension of wrist and supplied by the posterior interosseous nerve, right? Next one is extensor carpi ulnaris. Originates from lateral epicondyle of humerus and inserts at fifth metacarpal base on the dorsal surface. You can see all these in slides. Action is extension and adduction of the wrist. Extension and adduction of the wrist, right? This is the function of extensor carpi ulnaris, supplied by the posterior interosseous nerve, right? Next muscle we have lumbricals, lumbricals in hand, lumbricals, right? The function of lumbrical is flexion at MCP joints, supplied by median nerve. First and second supplied by the median nerve, right? And third, fourth is supplied by the ulnar nerve, right? First, second supplied by the median, third, fourth supplied by the ulnar nerve, umbilical, right? So next one is flexor digitorum superficialis and flexor digitorum profundus. Action is flexion at proximal IP joints and MCP joints of each finger, and also helps in wrist flexion, and supplied by the median nerve, right? Next one is flexor digitorum profundus, supplied by ulnar nerve, medial half of the muscle, and lateral half of the muscle is supplied by the anterior introitious nerve, right? So these are the muscles of forearm. First, you have to check the condition of muscle. You have to check MMT of the muscle, right? You have to inspect the area, right? You have to check function of the muscle. Then you can use cardiac stimulation on the motor points, right? So I have sent you all these slides. You have to learn motor points. You have to learn origin points, insertion points, actions of the muscles, all muscles, so that you can do this, right? So this is all for today. Tomorrow we will discuss another group of muscles and application of cardiac stimulation. So revise the chapter first, then we move forward, right? So any questions you want to ask, you can. Anyone? So revise the chapter. Tomorrow we will meet, right? Yeah. Okay, take care. Bye.